or TBI, whether you're a patient seeking clarity or a healthcare professional deepening your clinical understanding, this presentation is designed for you. Compiled by Dr. VTR Ntsanwisi, and together we'll break down the complexities of TBI, making sense of both the science and the personal impact. Let's begin our journey into understanding how brain injuries shape lives and care decisions. Imagine carrying the weight of a brain injury, sometimes invisible, yet profoundly life-altering. TBIs can cloud insight, leaving both patients and clinicians searching for answers. It's a reminder that, while the injury may not always be seen, its effects demand thoughtful handling and understanding from everyone involved. Have you ever considered how much care and effort it takes to support someone with a brain injury? The complexity and sensitivity needed in TBI recovery. Recovery isn't just physical. For both patients and clinicians, addressing these unseen struggles is key to effective treatment and true healing. So, what exactly is a traumatic brain injury? It's defined as any structural or physiological disruption of brain function caused by an external force, like a fall or accident. Clinical signs can range from loss of consciousness and memory loss to confusion, neurological deficits such as weakness or sensory loss, and even intracranial lesions. Recognizing these signs early is crucial for timely diagnosis and intervention, shaping both immediate care and long-term outcomes. Let's take a closer look at traumatic brain injuries worldwide. Each year, about 10 million TBIs occur, most often from falls and road accident. While mild TBI or concussion makes up nearly 90% of cases, even these can deeply affect quality of life. Axonal injury is a major culprit behind disability, and repetitive injuries may lead to chronic conditions like CTE. Accurate diagnosis relies on clinical exams, imaging, and emerging biomarkers, guiding personalized treatment for every patient. When we think about why neuropsychiatric symptoms can differ so widely after a traumatic brain injury, it's important to look beyond just the injury itself. 4 key factors come into play. First, a person's personality and temperament before the injury can shape how they respond to trauma. Second, family psychiatric history may influence vulnerability to certain symptoms. Third, any previous psychiatric, medical, or neurological history can affect both presentation and recovery. Finally, psychosocial, economic, and vocational status, such as support systems, job stability, and financial resources, can dramatically impact outcomes. By considering these factors, clinicians can better tailor assessments and interventions, ensuring that care is truly individualized for each patient's unique situation. But there's more to consider: the type, location, and severity of the brain injury itself, how someone emotionally responds, and the impact on their roles at home or work. These factors shape not only symptoms but also recovery paths. By reflecting on both the medical details and personal experiences, we can better support each person's adjustment after TBI, bridging clinical care with real-life challenges. Did you know that nearly half of all traumatic brain injuries in the U.S. are caused by falls? In fact, falls account for 47%, followed by being struck by an object at 15%, traffic incidents at 14%, assault at 9%, with other causes making up the rest. This data highlights how everyday risks, especially for children and older adults, can lead to significant injuries. Awareness is our first line of defense against preventable TBIs. Sports injuries are a significant and sometimes overlooked cause of traumatic brain injury, especially in high-impact activities like football. This slide visually connects the act of playing sports with the risk of brain trauma, showing a hand holding a football near a brain model with a red highlighted area indicating injury. It's a powerful reminder that even a single impact can lead to concussion or more serious brain damage. For athletes, coaches, and families, understanding these risks is crucial, not just for prevention, but also for making informed decisions about returning to play. Recognizing symptoms early and prioritizing safety can help protect both short-term health and long-term brain function. Warfare stands as one of the most significant causes of traumatic brain injuries. In the chaos of combat, soldiers face not only visible wounds but also hidden trauma from blasts and impact. What risks do these intense environments pose to brain health? Both direct injuries and shockwaves can have profound, lasting effects. Reflecting on these realities helps us understand the critical importance of prevention and rapid intervention in military settings. Motor vehicle accidents, or MVAs, are another leading cause of traumatic brain injury. Imagine a single moment on a rainy highway, sudden impact, flashing lights, and lives forever changed. How do such incidents affect the brain? The force from a collision can result in both immediate and long-term cognitive challenges. For patients and clinicians alike, recognizing these scenarios is essential for timely diagnosis and treatment planning. Not all traumatic brain injuries happen the same way. Let's break down 3 major types: direct impact injuries, where the brain is struck directly; acceleration-deceleration injuries, often seen in whiplash or sudden stops; and shock wave injuries, which are more common in explosions. Each type damages the brain differently, underscoring why tailored assessment and care are so crucial for recovery. Blast injuries add even more complexity to brain trauma. Primary blast injuries come from the pressure wave itself, potentially damaging the brain without any visible wound. Secondary injuries result from shrapnel or debris, while tertiary injuries occur when the body is thrown against a surface, causing the brain to rebound inside the skull. Understanding these mechanisms helps both patients and professionals anticipate symptoms and guide effective care. Let's explore coup and contre-coup injuries, a common result of blows to the head. When the head strikes a fixed object, the brain first impacts the side nearest the blow, causing a coup injury. Then, it rebounds, striking the opposite side, the contre-coup injury. This back-and-forth motion can lead to widespread damage, even if there's no outward sign of trauma. Recognizing this pattern is key to understanding hidden TBI risk. Think about what happens when a baseball hits someone's head. The initial impact causes the brain to crash against the inside of the skull, the coup. Then, as the head snaps back, the brain slams into the opposite side, the contre-coup. This dynamic process helps explain why even a single blow can result in multiple injury sites within the brain, emphasizing the need for thorough clinical assessment after any significant head trauma. Hidden injuries reminds us that not all wounds are visible. Traumatic brain injuries often leave scars that can't be seen, what we call invisible wounds. These subtle changes can affect memory, mood, or thinking long after physical healing appears complete. It's vital for patients, families, and clinicians to recognize these unseen impacts so no one feels alone or misunderstood on their path to recovery. TBI, hidden in 3 aspects. Why are some traumatic brain injuries so difficult to detect? First, diffuse axonal injuries may escape imaging tools. Second, many effects aren't physically obvious. They show up as changes in behavior or thinking. Third, even skilled examiners might miss them, making these truly invisible injuries. Awareness is the first step in ensuring no TBI goes unrecognized or untreated. How do we classify TBI? Clinical severity ranges from mild to severe based on criteria like consciousness loss, amnesia duration, Glasgow Coma Scale scores, imaging results, comorbidities, and outcomes. Mild cases often recover fully but may have lingering neuropsychiatric issues. Moderate TBIs bring chronic symptoms, while severe cases can cause lasting disabilities, or even death. Knowing these distinctions helps everyone make informed decisions about care and rehabilitation. Let's explore how the Mayo Clinic classifies moderate to severe traumatic brain injuries. According to their criteria, a TBI is considered moderate severe if any of the following apply: death resulting from the injury, loss of consciousness for at least 30 minutes, post-traumatic amnesia lasting 24 hours or more, or a Glasgow Coma Scale score below 13 in the first day, unless factors like intoxication or sedation are involved. Why do these details matter? They guide both diagnosis and early treatment decisions. Another crucial part of the Mayo classification involves specific types of brain injuries. If even one is present, such as an intracerebral, subdural, or epidural hematoma, a cerebral or hemorrhagic contusion, penetrating trauma where the dura is breached, or a subarachnoid hemorrhage, the injury is classified as moderate to severe. For clinicians and patients alike, recognizing these conditions is vital, as they often require urgent intervention and can significantly affect recovery outcomes. What if none of the severe criteria apply? The Mayo system then considers mild, or probable, TBI. This includes cases where loss of consciousness lasts less than 30 minutes, amnesia is brief but under 24 hours, or there's a skull fracture without penetration of the dura. For patients, this means symptoms might be subtle yet still important. Clinicians use these distinctions to tailor monitoring and care for each individual's need. If neither moderate-severe nor mild criteria fit, Mayo's Criteria C looks for possible TBI based on symptoms alone. These include blurred vision, confusion or mental state changes, feeling dazed, dizziness, or focal neurologic signs. Why is this important? Even mild symptoms can impact daily life and may indicate underlying injury. Both patients and professionals should remain alert to these warning signs, ensuring early recognition and intervention. Let's visualize some common symptoms of traumatic brain injury. These range from loss of consciousness and persistent headaches to more severe issues like coma or seizures. Other warning signs include confusion, dilated pupils, slurred speech, and unusual behavior such as anxiety or agitation. Recognizing these symptoms early can make a crucial difference in treatment and recovery, whether you're a patient noticing changes or a clinician assessing someone at risk. Traumatic brain injuries affect people in many ways: cognitively, emotionally, behaviorally, and physically. The checklist here highlights symptoms from memory problems and mood swings to fatigue, headaches, and even changes in personality or sleep. For healthcare professionals, tracking these across domains helps build a complete picture of a patient's experience. For patients and families, it shows why ongoing observation and open communication are so important after a head injury. It's important to recognize that certain factors can confound clinical assessments like the Glasgow Coma Scale and estimates of loss of consciousness or amnesia. Things like intoxication, shock from blood loss, sedation for medical reasons, intubation, or facial injuries can all cloud the true picture. Both clinicians and patients should consider these confounders to avoid misinterpretation and ensure accurate diagnosis and care planning. Effective TBI assessment begins with asking the right questions. Clinicians probe for details about accidents, falls, sports injuries, explosions, or assault. Key follow-ups clarify whether there was loss of consciousness or memory gaps before and after injury, essential for understanding severity. Patients can help by sharing what they remember and how they felt immediately after the event. This collaborative approach leads to better diagnosis and personalized care. Further questions help paint a fuller picture. Did you sustain other injuries? What problems followed? Has anyone noticed changes in your behavior? Gathering input from witnesses and exploring substance use at the time of injury provide context that can influence both symptoms and recovery strategies. Recognizing prior head injuries is also key. Each incident adds risk for future complications. Honest answers empower both patient and provider to make informed decisions. The Glasgow Coma Scale, or GCS, is a fundamental tool used to assess a patient's level of consciousness after a traumatic brain injury. It breaks down into 3 categories: eye-opening, motor response, and verbal response. Each category has clear examples, like responding to commands or questions, with scores ranging from best responses to none. By adding these scores, clinicians get a quick and reliable measure of coma severity, guiding both immediate care and ongoing assessment. The Galveston Orientation and Amnesia Test, or GOAT, helps us understand how well someone recalls events and stays oriented after a brain injury. This form collects details about the patient and tracks their memory for things like dates, names, and recent events. Clinicians use error points for incorrect answers, subtracting them from 100 to get a final score. GOAT is especially valuable for identifying post-traumatic amnesia in hospital settings, guiding early treatment decisions. This detailed GOAT assessment table covers essential questions, from recalling your name and birth date to describing events before and after an injury. Each question has notes clarifying what counts as a complete answer, and error scores help clinicians measure gaps in orientation or memory. By breaking down responses this way, the test pinpoints specific areas where support may be needed, turning personal history into a practical guide for rehabilitation planning. Continuing with the GOAT assessment, this section focuses on time and date orientation. Question: